I'm Del Berry, the Dean of Global Health, the Director of the Center for Innovation and Health in Global Health. And it's my pleasure to actually introduce this conversation. So Rick is an extraordinary physician who has worked more than 35 years on the ground in Ethiopia. He went to college at Middlebury College and then medical school at the University of Rochester. And then he went on to train in internal medicine at Hostels. In 1984, I don't know if many of you remember the famine, and it was quite horrible in Ethiopia at that time, and he went over as a relief worker. And I think the rest is history. He returned on a Fulbright fellowship and actually really kind of stayed there after the Fulbright, basically responding to many of the unmet needs there in spinal disease, pneumatic heart disease, and really certain cancers. And he was hired by the American Jewish Joint Distribution Committee, JDC, to care for 25,000 potential immigrants to Israel. He's also part of Operation Solomon, which airlifted over 14,000 Ethiopian Jews to Israel. Currently, he serves as the medical director of the JDC's FIND program based at Mother Teresa's mission in Ethiopia, where his actual mission is to bring the highest medical care, primarily to pediatric patients, as well as adults. Rick is an unusual way of going about treatment for patients that aren't able to access care. For basically the pediatric patients, he goes ahead and adopts them. And with adoption, he's able to send them to a different country to get the exact final treatment that they can. He's adopted 5 children and has anywhere from 10 to 12 running around his house at any one time. So he's got a unique way of working. He's also worked with vulnerable populations in Rwanda, Zaire, Tanzania, Somalia, Albania. He's also the senior consultant to Mother Teresa's mission. Rick has been celebrated as a ACP Rosenthal awardee. He's been the CNN hero. The Rosenthal Award is actually for the practice of creative medicine, an unusual award. His life story has been the subject of an HBO documentary, Make the Crooked Straight, and a book by Marilyn Berger. This is For Soul, the Mission of Rick Hodes. Thank you for joining us today. And then I get to introduce Paul Costello, who is our extraordinary interviewer for the Center for Global Health and Innovation. He's a faculty fellow, also a lecturer in medicine, but he has spent many years as the senior communications officer for the School of Medicine. He was a speechwriter for Rosalind Carter. He's worked in various other sectors of communication. And he really knows how to get to the heart of people. So I'm going to turn it over to Paul.
Thank you.
Yeah.
So I'm going to get at your heart. You know, in doing a background, when I prepare for these, I throw myself into it. And I tracked down your biographer in New York.
You did?
I did. And I talked to Marilyn.
She did not tell me that.
Yeah, I talked to Marilyn twice.
Wow.
And Marilyn Berger wrote his biography, and she was married to Don Hewitt, who was the executive producer of 60 Minutes. And the first thing I didn't even open the conversation with her. And I said, so just tell me about Rick. And she goes, he is hysterically funny. And that was the first thing she said to me. And then I spoke to two other of your friends, and they said the same thing, that you were very funny, very humorous. And it made me think about humor and how humor sustains us. And you work in one of the most desperate places on earth, quite frankly.
Yeah.
and you work with some of the most needy people on earth. And tell me and tell us about, how do you keep a sense of humor when one would think that in that environment you couldn't be jovial at all? How do you balance that?
So, I work in a city hospital. I'm in the basement. I'm in a large, I prefer to work in a large room with my whole team in front of me. So we can watch each other, not in a confrontative way at all, but just in a collaborative way. And I may have 3 or 4 other people working with me in other parts of the room. There's no ventilation and there's no water. Like, even if you go to the bathroom, there is a bathroom, we wash our hands with alcohol because there is no water at all. You don't flush the toilet either. The staff flushes the toilet once a day. So that's the situation. No ventilation. People come in, and especially if they've never seen me before, they're nervous. The kids are afraid, and I try to get them to laugh. And the way I do that, at first, Ethiopians have a naming system. So the Ethiopians have one name. Are you Ethiopian, you guys? Yeah. So Ethiopians have one name, just like we all have one name. But then on top of that is their father's name, then their grandfather's name, and so on. And they may know, depending on your ethnic group, the Oromos know 10 or 12, Amharas may know 5 or 6, but you know some generations back. And I'll say, what's your name? And they'll say, Abebe man, Getacho man, Getacho who, Feleke. And at a certain point, they say, I don't know. But the word for I don't know is alaukum. So then I'll say, alaukum man, like I don't know who. And like I say this 10 times a day, and they think it's hysterical that I think that one of their fathers, their great grandfather's named I don't know. And that's one of the things that I do at first to every patient to break the ice. And then I write it all down, and then I say their name to them, and then at the end I'll say alaukum. And they'll try to explain to me that like alaukum is not their name, and I won't listen to them. And even when they come in the next time, I'll read the whole thing again, and they start laughing. So I want every patient to come out a little happier.
Yeah.
And for myself, I tell jokes all the time. I tell jokes to my patients. I tell jokes to my staff. We try to understand each other that way. Because otherwise, it's quite depressing. It's, as Osler said, we're dealing with poor, suffering humanity all day long. And it can get really depressing if you don't, and the other thing is I get, at least once a day, I get completely overwhelmed. Like, I feel like somebody's just dropped a load of coal on me or something.
Is that because the number of patients that you have to deal with, is
Yeah,
the workload?
because and also like my philosophy is to see every patient the day they come. So even if it's only for a minute, like depending on where you're from or whatever, I will try to see you and see what I can do to help you. So we're sometimes in clinic till 8 o'clock at night, which is tough on my staff, and I appreciate that issue.
Take us back to N Drive, which is the street.
How do you know this?
This is the street you grew up in.
It is.
And I couldn't pronounce, I had to go to the internet to learn how to pronounce the town. Syosset, Long Island.
Yes.
And you grew up in that street, and you had an older brother who was...
No, I'm the oldest.
Oh, you're the oldest, and your brother was younger, but he was in sports, and you were not. You were a loner, sort of. Your mother described you as a loner. I didn't talk to his mother, but I read about what she said. When you think of those times and Drive and growing up there, what are the things that you left behind, and what are the things that still are with you today?
I've lived in Ethiopia I'm 70 years old, so I've lived in Ethiopia for half my life. But I very much feel like an American. I still feel like somehow I'm living in Long Island. Mm-hmm. Even though I'm not at all living in Long Island, and I'm living in I grew up in a 3-bedroom ranch house in the suburbs. Nothing terribly fancy, but it was fun. And now I live in a 3-bedroom, they call it villa, like a small house in Ethiopia, with a lot of kids and dogs and even chickens these days. I don't have water at home most of the time. I don't have electricity some of the time. But I still very much feel like an American. I mean, I like coming back to America, although I feel like Ethiopia is home.
How do you explain when you come here and you see a place like Palo Alto and you see, you know, this environment and you see, how do you help Americans understand Ethiopia, the work that you do? And when you go back to Ethiopia, how do you help them understand the world that you've left?
You know, it's interesting. My nurse has a daughter in Atlanta, and she went to Atlanta and she came back and she said, "Dr. Rick, I have even more respect for you now because now I see what you could be living in America, and now you're here." I try to I'm very flexible, but I prefer to. I feel like I'm having more meaning in my life being in Ethiopia and dealing with these people all day long. And at the end of the day, and I say this to myself every day, I'm living the life of my choice. Even if I'm not, even if it's difficult and whatever, a lot of people, I mean, none of us are living, we all have our issues and our employers and whatever, but, in that sense, I'm living the life of my choice. And I managed, when I was a little kid growing up in Long Island, I would read books about Albert Schweitzer and Tom Dooley, and I wanted to do that. And I had no idea how I was going to ever do that. And I come from a family that doesn't travel, and that, we never went, to Africa, we never talked about that stuff.
But you were a geography major.
Yeah, so so I went to Middlebury College, and I just decided I'm going to study geography. Now, my father's a businessman. My father's attitude was, you go to college to learn a skill to get a job. And I just went to college to go to college and study what I wanted to study. On the other hand, I knew my father was a very practical guy, and as soon as I finished college, he said, "Okay, the checks are ending." I'm actually more generous with my kids than he was. And, I had to get a job. But I ended up somehow going to Alaska. I mean, I painted some houses.
You went to Alaska after college.
After
and
college,
before med school.
Right. So I painted houses to make some money. I hitchhiked to California. I hiked the John Muir Trail with a friend. Hitchhiked to Alaska, where I had actually spent my junior year. And then I needed a job, and I said, "Okay, I'll get a job in a hospital." So I got a job in a hospital, and then I thought, well, medicine's pretty interesting, and I had a lot of time to read and think, and said, well, I should do something good with my life. So I went back to the University of Alaska and did pre-med.
Now, one of your, which you went to the University of Rochester that Michelle mentioned, and then you did your residency at Johns Hopkins. And I think I have this right in that you loved Rochester and the academic training there, but you didn't particularly love your residency at Johns Hopkins. And it was because I think the hands-on, the difference in between hands-on. Can you talk about that?
So I think I got really good training in both places, but Rochester was much more oriented towards people. Mm-hmm. Rochester taught us the approach to the patient. Like we were taught by psychoanalysts, literally starting in the first week of medical school. Like these guys, Morgan and Engel. George Engel was one of these iconic figures. And they taught us how to deal with patients, how to interview with patients. We would spend hours listening to tapes of students interviewing patients. And the psychiatrist would stop the tape and he'd say, "What is he saying? What is she saying? What does she need to hear right now? What does he need to hear right now?" And going back and forth like that. So we got this great appreciation of patients. And I didn't see that happening at Johns Hopkins. On the other hand, and I had one bad experience at Johns Hopkins that made me lose respect for the institution, although my chief of med, I admitted an Ethiopian refugee who had no health insurance. And
You were castigated by the head of the hospital.
right, so the head of the hospital, the head of Baltimore City Hospital called me up. Like, we don't even know who this guy is. Like, we're like pretty low, like for the head of the hospital to call me up and say, you admitted this patient doesn't have health insurance. Like, this is in the emergency room of Baltimore City Hospital. We never screen for insurance. And he said, this is the last time this is going to happen. Well, I at that point, I was a good note taker, and I wrote down everything he said, and I wrote him a letter, and I responded to what he said, and I also put it on every bulletin board in the hospital. And then I walked into the chief of medicine's office, who was a very lovely, reasonable guy named Phil Zeeb. And Phil, we called him Phil behind his back, but he's always Dr. Zeeb in public. But Dr. Zeeb said to me, you could have handled this different, but here's the bottom line. If tomorrow morning 50 uninsured Ethiopian refugees show up in the emergency room and need to be admitted, we're going to admit every goddamn one of them. Have a good day. And that was it. And like, the fact that I had his backing just meant so much to me.
And I assume.
And actually, when he died, I wrote his wife a letter, and I told her that story.
And I assume that he was one of the people that you learned your values from.
Yeah, him, and also I was in the general medicine division, and the boss there was a guy named Randy Barker. Randy Barker's a famous and wonderful guy, and we're still good friends.
I wonder if you think that altruism is, you're a incredibly altruistic person, and I'm wondering if you think that you're born with that. How did you become that person? How did you
I think you're born with it.
You think you're born with it?
Yeah, like I would be classified by these scales as an extreme altruist, but I just think that's my nature. And in fact, I actually at one point took in a child soldier in Ethiopia who had spent his teenage years killing people. And we took it as a project, me and the kids in the house, to rehabilitate him. And there's lots of adventures that we went through. But at one point he said to me, why are you the way you are? Is it your religion or is it your nature? And it was a beautiful question because I had never thought about it. And I said, no, it's not my religion. This is just who I am.
Let me ask you about your religion, because it's an important part of your life.
It is.
And you dabbled early. I use the word dabbled. You might argue with that, but when you were younger, you studied Roman Catholicism.
I was interested in history of religion and different religions,
like
and I checked out other religions and went to Quaker meetings and so on.
How did it become such a? And what is the meaning of faith and religion for you as a professional, for you in your personal identity, for the family that you live with, your children? How is that important to your life?
So I grew up in a secular Jewish home, and we did secular Jewish stuff, but we weren't religious. We went to synagogue several times a year and so on. But then, when I was in Ethiopia the first time, I was there from 85 to 88 teaching at the medical school, came back in 1990 to work for the JDC. I would listen to the BBC, and shortwave radio back then, okay, no internet. And BBC would have a religious program every day, and just, 10-minute thought of the day. And I would listen, and I realized when the rabbi, once or twice a week there'd be a rabbi, and he'd be talking, and I thought, this is so interesting. Like, why did I miss this the first time around? So then I thought, I need some remedial education. So when I left Ethiopia, actually to take a job with the World Health Organization in Burma, which was then canceled, I had just started reading about Judaism, and I thought that it has such a great depth, and it spoke to my heart. And I thought I should, this is who I am, and I should do this more. And so I got much more into it.
In 1984, when you went to Ethiopia for the first time, and then you went back as a Fulbright scholar, and then you were hired by the Jewish Relief Organization. What's it about Ethiopia that has such a tremendous pull for you?
Ethiopia is an amazing place, and there's a whole bunch of us. Like, I don't know if there are people who move to Rwanda or people who move to Nigeria who are so attracted to it. The way Ethiopia is a very unique place. You know, it has this ancient Christianity. Christianity arrived in the year 400. They have their own language. They have their own alphabet, their own music. I mean, it's like a whole different civilization. And I just liked it so much. And I felt so useful there because I was doing things that nobody else was interested in doing. So when I was teaching at the medical school, and I was in charge of the cardiology outpatient clinic.
And you weren't a cardiologist.
No, I was, quote, the closest thing to a cardiologist. But when I was doing that, I would get these kids who needed heart surgery, and then I started writing letters, and I found ways to get them surgery in America. So I started my first program to get, I probably got 12 or 15 kids surgery in the United States at different places, including the NIH.
And how did you go about building those partnerships of having children go? How did you raise the money? How did you go to the partner organizations, hospitals, institutions? How did you go about that?
So one of the first patients was a guy named Sebsebe. This isn't there's a lot of amazing stories. This happens to me all the time. But Sebsebe came to me. He knocked on my door. And he said, I heard you're a new doctor in town. He's about my size and much more muscular. And he said, I'm Ethiopia's top light flyweight boxer. And every time I train, I cough up 1 cup of bright red blood. Now, Ethiopians know that if you cough up blood, that you have tuberculosis. So he went to the TB center, and they said, no, you don't have TB. That's all they said. So another reason people cough up blood is they have mitral stenosis. Their mitral valve is too narrow. So I laid him down, and there's certain positions you put patients in. And I thought I heard mitral stenosis. Then there was one echocardiographer in Ethiopia, and I sent him, and he had mitral stenosis. So then I said, do you have $25,000 to get your mitral valve replaced? And he said, no. And I said, okay. And I said, write down your name and your phone number in case I hear of anything. The chances of somebody contacting me saying, I need patients to do mitral valve surgery, was 0. But I said, write it down. So he wrote it down, and I put it in my drawer and didn't think about it. 2 weeks later, I get my mail. Back then, the NIH used to send letters to every doctor in America asking for certain cases. And they sent a letter out saying, we're looking for patients with mitral stenosis to do balloon valvuloplasty. Okay? So I wrote them a letter. I didn't want to call my patient, so I wrote them a letter, and I said, would you accept Ethiopians? And they said, yes. So then I called my patient, and I said, come on in. And he came, and I sent him. He actually had enough money to pay for the ticket, or he had relatives who did that. This guy had his surgery. He ended up staying in America. He's now a boxing coach in Nashville, Tennessee, specializing in teaching boxing to Parkinson's patients.
Interesting.
And then more and more patients came with mitral valve disease. And then I got to know by email, or there was no email, by letter, the heart surgeons at the NIH, and they agreed to do other stuff. So, for example, I sent them a couple of tetralogies, and teenage tetralogies, and things like that. So they would have to raise the money because I had no money for tickets. But sometimes I could just ask somebody. They would find out what I was doing, and I'd say, do you want to give me $1,000 for an airplane ticket? And they would just give me the money, and I would buy a ticket. So
I'm curious about your practice there during all of the upheaval, the political upheaval. When you first got there in '84, Haile Selassie, I believe, was in charge of the government. And then, he was overthrown by the Marxists later. And then the Marxists were thrown out of power. Now, I guess you would say it's a democratic republic. And as you move through those phases, what impact did that have upon your work and healthcare in general in the country?
So when I arrived in Ethiopia, it was during the communist government of Mengistu Haile. Okay? Americans were not welcome. Doctors were welcome. Americans were not welcome. Jews were seen as being suspicious. Americans were all, quote, CIA agents or something like that. So the government kept an eye on me, and they still keep an eye on me probably. But I just try to keep a low profile and concentrate on my patients, and that's the way to do it. And that's how you can get confident. You can get people to have confidence with you.
The new government that's there now, the government that's
Right.
been in power for a little bit of time, are they trying to build an infrastructure that is a health infrastructure?
Very much, very much. And we've had, for a while, there were mediocre health ministers. Now we have a good, we've had several really good health ministers, including Tedros, who's now the head of the WHO. And now they're really trying to build up both numbers. So there used to be one medical school in Ethiopia, then there were 3 medical schools in Ethiopia. Now, literally, there's probably 25 medical schools in Ethiopia. There's a huge amount of doctors who are being produced, some of them better than others of them. There's training programs in all sorts of fields. So, it used to be there were no residencies, and then there was just medicine and peds and surgery, and now there's neurosurgery and orthopedic surgery and all of this stuff. So, and now they're building these, like, for example, basically a medical city, so that they're building a cancer hospital and a heart hospital, and I don't know how they're managing to do this, but they're certainly moving forward in the right direction.
Do you see technology as being do you use any sort of technology? Do you see it as any sort of hope for the multitude, millions of people who are not able to come to clinics, et cetera, in Ethiopia? Do you think there is any possibility that technology can be extremely helpful here?
Yeah, I try to be a low-tech doc. So, I examine my patients. I take their shirt. Most of them are spine patients. I take their shirts off. I'll take 20 pictures in different bending positions and so on. Now, and also I approach this as an internist. So, for example, one of the things I pointed out yesterday, when you stand up and your hands touch your knees, you've lost half of your lung capacity. And so I take a picture of the hands and the knees of every single patient. And then the only tech that we do is we have a breathing machine to do basic spirometry, and then we do x-rays, just AP and lateral. So that's my basic tech. And then if we're really doing a spine workup, we may get a CAT scan, and we often get MRIs, because you need to do an MRI. CAT scans are good for bones, MRIs are good for the spinal cord, and often these people have anomalies of the spinal cord, like split cords and things like that. So we need to check for that, we need to check for that very carefully if they're going to have surgery.
What are the mental health problems that they bring to you? I would imagine that these kids, mostly the young kids that you're dealing with, have significant, they're living out on the street. They don't have any family situation. The families abandon them in many respects. What are the mental health components to treating them?
So my patients are marginalized. They have spine deformities. They may be taunted in school. And there's a word in Amharic, Goata, which means hunchback. But it's a bad word. And they're called Goata. And I always ask, do people tease you in school? Do they call you Goata? And then I sit down with them and I'll say, listen, I'm going to tell you a secret. Before I was a doctor, I was a famous boxer in America. And I was so good that I wanted to fight Mike Tyson, and I called him up. And Tyson was so afraid of me, he wouldn't even take my call. And I said, can I go to school with you and be your bodyguard? And I'll say this, I say this 5 times a day to these kids, and I say, do any kids in your school have bodyguards? They say, no. I said, do any kids in your school have a friend, a white bodyguard? They say, no. I say, I'm going to go to school, I'm going to sit next to you, and if I hear the word Goata, they're going to end up on the moon. And it just makes them feel so good that I'm in their corner, literally.
What is your home life like with, how many kids are living right now?
Right now, well, some of them are my relatives, so they're not just strangers, but probably a dozen.
A dozen.
Yeah.
How do you, you go from an intense work environment, you go back to an intense situation at home.
No, it's not intense at all.
It's just.
No, it's quite relaxed. It's not.
How is it quite relaxed with 12 kids?
We all live together, and Ethiopians don't need a lot of personal space. They don't, they don't want to be alone actually. So Ethiopians are never alone, and so we all live together. I have my side of the house, but people live there. They go to school. They come home. They stay in the living room. They study. We all have Friday night dinner together, and the idea is it's a Jewish house. Everybody is welcome. The kids are Christian and Muslim, and we all celebrate the Jewish Sabbath together. We stand in a circle. We hold hands. We sing "If I Had a Hammer," Pete Seeger's song. I bless all of the kids individually, and then we have dinner. We do this every Friday night. We do things. Sometimes we'll take a trip on a Sunday or something. So it's not intense at all at home. It's quite relaxed.
What are you most proud of in your career when you look back at your life? You said you're 70 now?
Yeah.
You've been doing this for many, many years. What are you most proud of?
As every year, I see the fruits of what I've been doing. So in 1999, I got 2 abandoned orphans. I couldn't get them surgery, and I adopted them and added them to my health insurance. That was it. I had no dreams of becoming a spine doctor, Another kid came along. I repeated the process. You can't keep on adopting. Then I met Dr. Boachi. And again, this is like a meeting arranged by God. And then we started working together. So in 2006, we opened up our spine program. And we got that year 20 new spine patients, and we did 11 surgeries. And I thought, oh my gosh, I can't believe how well we're doing, because I had to do fundraising and get these people to Ghana for surgery and so on. And now we've done 1,500 surgeries. We've put Ethiopian spines on the map of the world. We're training Ethiopian doctors both inside Ethiopia.
When you say you put them on the map of the world, what do you mean by that?
Everybody all the major spine surgeons in the world all know what we're doing in Ethiopia. They know about the situation. They've seen, like for example, Dr. Boachi gave the keynote speech at the spine meeting in Seattle some weeks ago. Literally 50% of the images he showed were my Ethiopian patients. And there is a study right now, it's called the Fox study, of the most difficult spine surgeries in the world. Half of them are my patients. So we're like making a major impact on spine disease, spine deformity around the world. And I think that's what I'm most proud of. That, we started from nothing, and it was just one step at a time. I didn't think I would ever become a spine doctor. And then as I got more and more patients, and I thought, hey, this is pretty interesting, I better learn something. And I started reading more, and I spent, Dr. Boachi and I would spend days together in clinic, and it would be like a tutorial, because here I am, it'd be like, I'm an internist, I don't know anything. And then, but I would be with the master, and he would point things out. And then, now, I can fly on my own.
How has your practice changed over the years from the initial point of when you started doing the surgeries to today?
So now I'm getting more and more patients. We're getting 500 new deformities a year. And then I'm getting, we go into the countryside, we'll go to Owasso, we'll go to Deborah Burhan. Deborah Burhan is by far the worst. And we'll get another 50, another 200 patients. So I'm flooded with patients. I have to raise the money, and we have to train doctors, but also I have to send patients abroad. So right now we probably have 4 or 5 patients in Ghana for traction and surgery. We have 5 patients in South India, in Tamil Nadu right now. It's our new partnership, which is even maybe in some ways better and cheaper. So it's expanding, and it's more stressful for me, but it's going okay.
How much money do you need to raise, and how do you go about it? Where do you raise your money from? Does the government participate at all in
The
it?
government was, for a while, they were buying airplane tickets for us, then they figured out that it was not legal, so they stopped. But I have a website, Hodes.org. I work for the American Jewish Joint Distribution Committee. They don't give us money, so I'm working under them, but it's sort of like an independent program, so I have to raise the money. And I have a website, and I talk to people, and I meet people, and some years I would like to raise $1 million a year. Some years I do, some years I don't. Just depends. And like now, towards the end of the year is when a lot of Americans give charity. So now we'll come up with a brochure, and I will send out at least 500, if not, 700, 800 copies of our brochure with a handwritten note to my donors saying, please donate something to keep us going. And some people give, $10 a month, and some people give $100,000 a year. So. Yeah.
One of your friends told me that the word vacation is not in your vocabulary. And they said, there's no way, he doesn't know anything about vacation. Is that
So actually I've been trying to work on that. And what I did, this year I haven't had a vacation, but some things what I want to do is at least be able to work in a stress-free environment. So I will buy an airplane ticket. I have a lot of miles, so I can get a ticket to India, or have a 5-year visa, or Thailand or Cambodia or something, and just work from there for a week. And it's at least working from a different environment.
A semi-vacation.
Right, that's Rick Hodes' idea of a vacation. But I do, one of my plans for 2024 is to actually go on some real trips.
What has been the biggest surprise of your career, and what's been the biggest challenge when you look at, and obviously the numbers you're dealing with are a great challenge, and the numbers that grow. When you look at, the span of time that you've been practicing, what are the greatest challenge? What, is it raising money?
My biggest surprise is my success, frankly. I just sort of taking one step at a time. And the fact that we now, we've done 1,500 surgeries and we're getting so many new patients and so on, it's a sign of our success. And the challenge is keeping up with all of that. And also raising money to keep us going. Because the more money we bring in, the more surgeries we can do. And the more training we can do of doctors.
You mentioned the healthcare sector and that the government is trying to really build it. What is the public health sector like in Ethiopia? Is that being also built besides?
It is. There are regional health departments all over the place, and we show up. I mean, we work with them quite closely because we go out into the countryside, and they really want to improve things. I mean, they're very motivated. They're really trying their best to make things better.
Is this the first time you've really seen that motivation from the government?
I wouldn't say so, but I'd say it's getting better. They've been working on it for some times, and sometimes it's better and sometimes it's less good. But right now, we're working very closely with the Ministry of Health, and they're really cooperative. They really want us to succeed, and they're trying to help us.
I know that Mother Teresa has been an inspiration for you, and that you work closely with the sisters of the order that was Mother Teresa's. And you met her once, I believe.
I met her a couple times, actually, yeah.
What was it about her that inspired you? And when you think of the work that they do in India and Ethiopia and elsewhere, tell us about them, the order, and Mother Teresa, and the inspiration you got from her.
Mother Teresa also started out small, and now she has this worldwide order of these priests, but also mostly nuns, and they consider their mission to take care of the poorest of the poor. So people show up and they're tough. I mean, these are not these are very tough women, because people, if they had their way, you know, there would be 1 million people moving in and staying forever, and they have to say, like, you don't come in, or you only stay in for 3 days, and so on. It's not an easy environment for them, but they probably have about 12 centers around Ethiopia, and they're like low-tech care centers. Sometimes they have doctors, sometimes they don't. Sometimes they're taking care of mentally ill or chronically sort of, you know, cerebral palsy type kids, and sometimes they're just taking care of sick people who are day laborers in Addis Ababa, but they come down with malaria, and they need a place to sleep for a week while they get better. And they work, I mean, like, they get 2 weeks off every 10 years to go back to their,
generous.
yeah, to go back to their homes, and that's it. Like, they take a vow, you know, and this is their whole life, you know. Like, I go to the gym every morning.
And you swim.
And yeah, I swim, and I go to the gym every day before I go to clinic, you know. And you know, people think that I'm suffering so much in Ethiopia, but you know, like, I have a bit of a normal life. The nuns don't do anything like that. They, you know, and I've been in their bedroom, because literally when they get sick, they call me. I mean, and they sleep in a room with 20 cots, and they're just, that's their life. That they eat, they sleep, they pray, and they take care of the poor, and this is their life. Most of them are Indian. Some of them are from Eastern Europe. A few are from Western Europe. We had one American who didn't succeed and came back to America. So, yeah.
One of your friends told me that the last time that you usually stay at the Y in New York because of the
I'll be
pool.
there tomorrow.
Because of the pool, because you're swimming. And this person,
But it's also the cheapest place to stay.
yeah. And well, then the person told me that, you know, the last time you were in New York, I guess everything, you know, the Y was filled because there was UN or something of that sort, and you stayed at a hostel.
I stayed at the youth hostel.
Yeah.
In a room with 12 other people. That was fine, because there's no way I was going to spend $300 for a hotel room when I could spend $70 and get a room, get a bed in a room with 12 other people, and that was perfectly fine. It was okay, and like, I'm using donor money, and there's no way I'm going to spend $300 for a hotel room.
A very humble position to take, a very, you know, to do what you do.
Yeah.
This person who told me it was just marveled that, you know, when he couldn't get into the Y, where did he go? He went to a hostel.
Yeah.
And he slept in a room with 14 other people.
Yeah.
I wonder, is there any time that you second guess what you do and say, do you second guess it at all?
Yeah.
And what is that like?
On the other hand, you know, something like that, I have no doubt that I did, you know, I did the right thing. And sometimes people from inside my organization say, Richard, you can spend money, it's okay. You know, it's like, I can't do that. You know, I'm not going to stay in a regular hotel.
What's the succession plan? It's you're 70.
Yeah, I'm 70, so I'm keeping on going. We are training doctors. We have an orthopedic surgeon right now at Ganga. Hopefully he's going to become qualified to do spine surgery. The problem is, I'm an internist. I trained in outpatient medicine, so I'm happy to see patients all day long in my office. Orthopedic surgeons and the surgical types don't want to do that. So I'd like to train an internist or a family doc or something like that to take care of the outpatient stuff and the initial stuff. And then when it comes to surgery, turn it over to the orthopods. I haven't found somebody like that yet who wants to do that and work with us. But the idea is within the next few years to have it run by Ethiopians. I mean, people say, and for example, there's another Christian organization that I'm working with called Cure. And Cure approached me and they said, would you mind if we started a spine program? And I said, mind? I said, I'll help you. You know, I said, I'm not trying to be the owner of spine. I'm trying to be the father and have as many children as I can. So, you know, it's not like, you know, we're getting, I mean, if somebody just gave me a blank check, I could easily come up with 2,000 people right now who need spine surgery. So we need much more capacity. And this is just in one neglected field. I mean, and there's lots of other neglected fields as well. For example, I'm getting people with Down syndrome who have endocardial Cushing defects. It's like an ASD, VSD. And most people, no organization will do free surgery on that. And I talked to one of my friends, and she's now starting a program to do free heart surgery on kids with Down syndrome. She has done 4. Do you know how long the waiting list is? 5,000 patients with Down syndrome who need heart surgery in Ethiopia. So,
Pretty extraordinary.
yeah.
Let me close by asking you a final question about, for physicians and students who want to do global health, what's the inspiration? What can you tell them about why to do it? What's the passion?
Okay, first of all, it comes with a warning. It's not easy, okay? You're not going to be comfortable. You're not going to be rich. You have to figure out how you're going to support yourself. My friend Jill Seaman, who's in South Sudan, works in South Sudan half the year and Alaska half the year to support herself. Unless you come with family money, which I wish I did, you know, just the way to do it is not easy. On the other hand, for me, knowing that I'm changing the lives of people who nobody else cares about and who would never have a chance otherwise, that's what keeps me going.
Thank you, Rick.
I think we want to open it up for questions from you guys.
Thank you so much.
Turn off yours.
Sorry, my voice is not so very loud, but thanks so much. I arrived a little bit late, but I know it's not probably an easy question to answer, but think about really a more investing aspect to give it more, I would say, more capacity, right? In not just in medicine, but in genomics. You know, I do not know really what type of genetic disease is common in Africa or Ethiopia, but what are some of your thoughts that we can kind of encourage and motivate investors? I'm in a kind of venture worlds, you know, from startups, but I've been thinking a lot about the global genomic medicine, and what are your really perspective on that? How we can take some leads to really get funds, you know, support to do something. I do not know, but I think it's, as you already even in the charity, you have some difficulty to fundraising, let alone
So,
ventures.
right, that's an interesting idea. Ethiopians are a combination of African and Middle Eastern genes. They are unique. We don't have sickle cell. We don't have large keloids. So it's more of a Semitic type diseases and genetics. But there's great possibilities. Like I met recently with some company in, and I'm trying to get them interested. They want to expand and look at certain genetic conditions. And I said, come to Ethiopia and we can arrange for some sort of study. I don't know, this is not my field at all, but I think there's great potential. I mean, for example, just, you know, I've made the diagnosis of Emery-Dreifuss muscular dystrophy, which is very rare. The other day I proved the diagnosis of facioscapulohumeral muscular dystrophy, which nobody has ever proved in an Ethiopian before. And we actually we have sequencing on that patient. So I think there's some possibilities. If you have any ideas, we can talk.
Thank you so much, first off, for speaking with all of us at Dr. Hodes. I wanted to ask you, what are your thoughts on the kind of opportunities and the challenges that larger philanthropic organizations have with, kind of successfully implementing global healthcare improvement initiatives. I'm thinking mostly of, organizations like the Gates Foundation, or even, kind of larger governmental bodies such as USAID. How can these kind of agencies do a better job of, achieving longitudinal global healthcare improvement?
Gates has a certain perspective on how to do things, and certain things they're interested in funding and not interested in funding. They are not interested in funding me, for example, seriously. But they certainly are very dedicated, and they're putting a lot of money into prevention and things like that, and in vaccines and certain public health initiatives. I don't know that much about the Gates Foundation. USAID also I don't know that much about. I don't have that much to do with them, but so I can't say what they should be doing differently or anything like that. I know under Trump, the number 2 at USAID was she was a close friend and a developmental professional who knew what she was doing. So at least quality of staff, they're good. And also right now under Biden, what's his name? There's some
USAID.
yeah, one of these famous Atul Gawande is with USAID right now. So they certainly have qualified people. That's all I can say. On the other hand, like I know, you stay in Africa for a while and you see all these unsuccessful things, and don't just send doctors, don't just helicopter in, I've seen that so many times where some team is going to come and they expect everything to be there and nothing is there and they get upset, and there's a lot of bad feelings and so on. That's not the way to do things. You need partners on the ground, you need to be prepared, you need to be culturally sensitive and so on.
Thank you.
Just to expand on that question, hi. For those of us, I guess, what advice would you give for those of us who are interested in doing work globally? But from my perspective, I try to think about in years to come for this global health to be more of a partnership, which I think a lot of people are moving towards, but less of, like you said, people going back and doing philanthropy, but having people like these countries or these communities be able to stand on their own where it's more longitudinal. And what can we do to make that shift at this point?
So you need partners on the ground who want to do it and who want to stay there. One of the big problems in Africa in general, and including Ethiopia, is the brain drain. So there's lots of stories of Ethiopians who come to America and they never go back, all the time. So now anyway, so that's one of the issues. On the other hand, you need good partners, and you need people who really want to learn. And then if you have a collaborative project, you can do it well.
How do you get...
there was for example, we had very few lung specialists in Ethiopia. And then Michael Bloomberg and company funded, it's not the best way to do things, but they funded people to go, every 3 weeks and teach at the medical school. And now we have pulmonary specialists. So Bloomberg had money and he got it done.
How do you, just to follow up on that, I guess kind of going back to how do you attract investors to invest in these things, especially when the return on those investments may be more of a altruistic, giving than them getting something in return? Because it sounds like a lot of this required money. Like you, with all the work you've done, you needed funds to get it off the ground, and you could say this was less for the people who gave the money, like may not, except the ones who did studies, but how do you get people to see that, to invest in these altruism things that may require them to come back less to Africa and to help these things sustain, for them to be able to sustain on their own?
If you can show people where their money is going and that it's being well spent, and that you're changing lives, that's a good start. On the other hand, if you're just sort of throwing money at a problem, that's not. So you need to be able to show people where their money is going and how it's changing lives. Like when I show the pictures of my patients and how it's changing their individual lives. People care a lot more about, like Nick Kristof wrote something about, like saving the Kosovo, puppy or something like that. That people want to know. They want to see one thing that's changed as opposed to we did 100 surgeries. So you need to appeal to both.
You mentioned sending patients to India and Ghana for surgery. Do you think that global mission trips and sending patients abroad is inhibiting Ethiopia's capacity to eventually do these surgeries?
Not at all. That's a good question. In our case, we also do surgeries inside Ethiopia. And we have, including Serena Hu, the chairman of spine here at Stanford, who is recently in Ethiopia operating for 10 days. So the best way to do it is to build capacity would be to have foreign doctors come in and work collaboratively with Ethiopian doctors and teach them how to operate. And that's a slower process. Serena can do a case maybe in 3 hours, but if she's going to be teaching, it could be a 5-hour case. She's willing to do that, but that's how it has to be done in order to build capacity.
Proportion-wise, how would you see that transitioning in the next 10 years? Like how many will be done in Ghana, India, and then Ethiopia in the next 10 years?
Hopefully in 10 years, 80% will be done in Ethiopia. Like the experts in Ghana and India are like as good as you get anywhere in the world. So we could send the much more difficult cases to them. But the average case should be, maybe even in 5 years, we should be able to do those in Ethiopia. I mean, we used to have no heart surgery in Ethiopia. Now there's at least 2 heart surgeons, and they're doing heart surgery in Ethiopia. So.
And what are the rate limiting steps to be able to have that capacity for Ethiopia to do those surgeries?
Okay, you need training, but you also need support. Like for example, there's an Ethiopian who got really good heart surgery training in Israel and Australia, and then he came back and he didn't find a good environment, and now he's working in Rwanda. I mean, he's still on the continent, but it's our loss that he's not working with us. And but I don't know exactly the issues with him personally, but it's we lost this guy and his skill.
So I'd like to just end there. We want to thank both Paul and